Yeah, I won't. I just have my head down.
You ready?
Yeah.
Okay, hello, my name is Tamika Blue. I'm a student at Columbus State University, and I will be presenting my presentation on fall prevention in the acute care setting. Okay, so the definition of a fall is pretty much a person that's being assisted to an unattended surface by a person. The history behind falls is that it's been a problem in hospitals for decades, and it's come to the point where the hospitals have stopped. I mean, the insurance companies have stopped paying for it. The average cost for a person who has fallen and had gotten injuries is $1,400, and the insurance company stated that they will not be paying for it. So, what are the risk factors? So, biological, behavior, and environmental. Biological is anything that allows the body to where it's going to cause a fall, like muscle weakness, medications like blood pressure medications, narcotics, even patients with peripheral neuropathy, which causes them not to be able to walk properly. Behavior could be someone who's in a CWAP protocol. It could be somebody who's inactive, like a bariatric surgery. Environmental could be poor lighting at night. It could be the room design where the chairs are not positioned properly. You may have a patient's tray that may be in the way. You may have things on the floor. Anything that causes them to impede their ability to move back and forth to and from the bathroom. And you may have multiple factors operating at the same time. It could be a bariatric patient that may be on narcotics. So these risk factors cause these falls in the hospital setting. Okay, so pretty much my assessment as a nurse would be I'm going to first of all find out what is going on with the patient. If any of these risk factors are playing a part of the role in them falling, what am I going to do as far as a nurse to make sure that this fall doesn't happen? So we have the Morse fall score, which is the generic scale that most hospitals use. And what happens is that we ask questions like history of fall. Have you ever fallen before? Whether it be by medication or you tripped and fell. Secondary diagnosis could be they could have hypertension. It could be someone coming in for bariatric surgery that may have asthma. That would be considered yes for secondary diagnosis. Ambulatory aid. Do they use a walker? Do they use a wheelchair? Anything that helps them or assist them with walking. Is that something they would need at the hospital or something that we needed to provide? IV access. Yes, we would definitely want to put that because every person in the hospital has an IV access. In the event we need to give them medication, we need to be able to access we need to have an IV access for that reason. Plus on top of that too, patients that have IV access normally have normal saline or lactated ringer going through their IV lines. So those could also impede someone's ability to walk with all the equipment that they have to utilize. Their gait, do they shuffle? Does it take them a long time to walk? Do they have any issues like peripheral neuropathy that's causing them not to be able to walk properly? Mental status, are they forgetful? Are they able to understand that they're not able to walk, and do they still try to walk anyway? This assessment tool helps us score them. So if they're score a 35 or higher, they're considered a fall risk, and we have to make sure that we let everybody that deals with that patient know. Okay, so with effective communication, we have to make sure that we are telling the next nurse, okay, this person is a fall risk. We want to make sure that they have the ambulatory aid that they need in order for them to be mobile in the hospital. Are you getting clarifying information? Are you asking the next nurse or whomever's giving you a report? Are you asking them if they are a fall risk, just to make sure that you're providing better care? Are you reading and repeating your information given? Are you making sure? Are you clarifying all the information that they're giving you? And are you giving effective handoff? Are you allowing the nurse to be able to provide the information, provide the care that is needed for the patient based on the information that you're getting? And when I'm getting a report from another nurse, what I always do is I always re-ask the questions again, just in case we miss something. Okay, so protocols. We have protocols with the right slide. Hold on. Okay. when we're in the hospital and we have protocols, these protocols prevent a lot of things, like prevent falls in the hospital. So are we explaining to our new graduates how to use this tool correctly? And that was one of the issues that is actually in my facility, that the new graduates are scoring the patients too low, and by the time they're reporting to the other nurse, the patients are falling. Do we need to do in-service? Do we need to allow the nurses that have been there the longest, or just been there longer than the new grads, are we allowing them to understand that the scoring needs to be correct? Are we doing in-service? Are we doing refresher courses? Just like we have refresher courses for blood sugars, we need to also have refresher courses for fall prevention. A lot of times when the patient's scores are recorded, they're not recorded correctly because the nurses are not doing it properly, and that's both the new grads and the nurses that have been there for years. Okay, so another thing that the question that came up was when I actually did a survey, and the nurses and the patient care techs stated to me that the reason why a lot of falls happen on our unit is because we don't have enough staff. So the average patient to nurse ratio on our floor is 5-to-1 and 6-to-1. The average ratio from patients to techs are 15-to-1. So with that being said, they're stating that there's not enough help that can get to these call lights in time. Not enough help to get to the the nurses are not helping enough because they're in another room, or the patient care techs are in another room. And then our patient acuity is high. If we have we don't have a step down unit, so therefore the acuity on our floor is pretty high. They move from ICU to our unit. Okay, so also too, when we talked about with fall prevention, how is your room structured? So we try to make sure that the room is structured in a way to where the patients can be able to move about to get from the bed to the bedside commode, or from the bed to the toilet. And we at nighttime, because I do work at night. At nighttime, what we do is we cut the bed alarms on. That is standard for our floor, and the reason why we do that is because again, with the way the room is structured, there could be things in the way. The bed alarm allows us to understand allows us to know when the patient gets up, so that we can get to the room in time, so we can be able to move things out the way, make sure they have their socks on, make sure that they that their lines are not in the way for them walking, so that it does prevent falls. And we have indicators. The indicators will be the yellow socks. It will be the yellow armband. It will be their door tag. That tells the nurse or anybody who deals with the patient, even patient care tech or the physical therapy or occupational therapy, it tells them that this patient is a high risk for falls. Okay, so how does this decrease patients' outcome and nursing effectiveness? Well, patients want to be independent. They want to be able to do things on their own. They want to be able to treat the hospital setting as if they were at home, and not have any limitations. Well, being that that's the case, the patient doesn't understand that they need to call us and let us know when they are ready to to ambulate. So therefore, with them having to do that, they feel like we're taking away their autonomy. So they're embarrassed. They don't want to tell us anything. And I have an example where our patient, she actually was a compliance manager, and she had her bed alarm on, and I turned it on, and she decided she wanted me to take it off, and she actually fell. She laid on the floor for at least 2 minutes before anybody found her, and we didn't even find her. It was the actual lab that found her. She was too embarrassed to call us. She didn't want to put on her socks. She refused everything. And with that being said, the patient, thank goodness she didn't sustain anything, but, explaining to her the reason why she should, be in compliance with, the things that we set in place for her not to fall, she just, because of her independence, she didn't want to do it. We had another patient that fell on another floor, and this resulted in death. The patient fell and they hit their head. They ended up getting a hematoma. CT revealed that they had bleeding in the brain, and 2 days later they died. And this was because the nurse did not explain to the patient's family that the importance of making sure that they have the proper socks on to where they can be back and forth to the bathroom, and they ended up falling. So patient's hospital stays, of course, is longer. They said it's an average of 6 extra days on top of what they came in there for. So there are 6 more days they're away from their family. And then, of course, the hospital's bottom line is affected. Again, like mentioned before, $1,400 it costs for the hospital because the insurance company's not going to pay for it. So it's $1,400 the hospital has to pay for the injury of the patient. Okay, so what is the root cause? So root cause would be family compliance. Again, the family doesn't want to comply with the rules. They want the patient to be independent, want them to be able to do what they want to do. Staff training and use of standardized tools. So that's going to be the staff making sure they're following our protocols, making sure they're using the Morse fall score correctly so that we can be able to provide better patient care. Patient compliance, the patient wants to be independent, want their autonomy. So we definitely have to make sure that we're explaining. And then it's an interdisciplinary team compliance. We have several people that deal with the patient's care, which from occupational therapy, speech therapy, physical therapy, pharmacy, everybody who's involved. They're not even making sure that the patient is, based on what, the care that they're given, like medication, making sure that their fall score is correct. So how can we fix this? Raising awareness, just making sure that both the nurse knows, both the family knows, and making sure that they're in compliance, and we are better understanding or better explaining why we have this protocol set in place for the family, just to make sure that they don't get hurt. Okay, so the interdisciplinary interdisciplinary fall prevention team. I believe that we should have a set of people that who all come together as a group, sit down and talk, and along with understand the plan of care. I think fall prevention should also be within that plan of care as well. They don't look at that number very, very often, and that's something that's missed and not discussed during the time that they have huddle. So during the time the nurses round, the doctors round, they're not talking about anything dealing with fall. Environmental services are the people who set up the room. Patient care techs are the people who answer the call lights and get them back and forth to the bathroom. Physical therapy, occupational therapy, pharmacy. Pharmacy is the one who deals with their medication. And of course, risk management. All these people are involved with the patient and can score them to where when we have the patient, we can be in compliance with what's needed for the patient to provide good care. All right, so the standardized tool, like I explained before, this is the Morse fall scale. This is what everyone has been using in the hospitals, and so it's been working when it's been used correctly. So so you have to ask these questions. Have you ever had a history of fall? And the secondary diagnosis, of course, that's on the chart. Ambulatory aid, you have to ask that. These are questions that have to be asked to the patient, and the nurses are not asking. They're just assuming, and then they're putting whatever numbers on there, and then whoever has the patient after that nurse is just going by the scores, and then they're copying and pasting whatever scores are on there, which makes it, they're not giving good care. And this is relevant because this tells us how to give care. Do we need to answer their call light quickly? Do they need to have on the proper socks? Do they need to have the call light on? The bed alarm on. Those things are important because if we don't put all these things in place, this patient is a potential fall. Okay, so individualizing care. This means that we have everybody is specific. Every patient should be individualized care. Should have individualized care. What medications are they on? Do they walk with a cane or walker? Do they need glasses? That's a lot of times the nurses don't score them on visual aid, or even say in their assessment that they wear glasses. The patients could fall if they don't have their glasses. Do they have a fall history? Did it result in injuries or fractures? Are they currently getting PT or OT? Some people come to our hospital and they're already doing physical therapy, and they're doing occupational therapy. But then when we have them in our care, nobody knows that, and then that could also potentially potentially they can fall with that because they're unaware of their ability. What does their daily life consist of? Do you want to make sure everything is in reach for them? I had a patient where nobody knew he was blind. So when we went in there and I'm looking at him, he's not looking at me, and I'm asking questions, and eventually my assessment revealed, and the other nurses were saying they didn't even know. But that's a part of an assessment. You have to make sure that the patient, you individualize care and make sure that you're putting the right information so that we can provide better care. Are they getting enough sleep? Are they actually sleeping? That's a big deal, because during the nighttime is when majority of the falls happen. So if they're not sleeping, they're walking around, they're doing something. So we want to make sure that they're getting enough sleep so they're not dizzy and falling. I also think too that one-to-one education, we need to make sure that we're educating the patient and their family. So right now, what do we have in place? We have the effective handoff. We have the one-to-one patient and family education. And right now, the effective handoff, like I said, that has to work only if the nurses are doing the scores correctly. And the one-to-one patient and family education, I think that we cover what can cause the falls, what the risk factors of the falls, what can be prevented. We set goals, and then we keep reviewing as the longer the patient is in the hospital, we keep reviewing those goals and make sure we involve both the family and the patient. Okay, so we have the post huddle, which is after the fall occurs, we have to sit with the patient, the family, the doctors, and everybody that was involved, like the nurses or patient care tech or who was ever there at the present of the event. We have to sit down and we have to actually have a huddle about what happened and what could have been prevented. So why did the fall occur? Was it medication? Did they not have their proper gait utensils? Could we have prevented it? What all tools did we use to prevent it? Did they have on their socks? Were there tubes in the way? How was the room set up? We have to analyze the contributing factors, like did they take some pain medication and now they were dizzy? Did we not tell them, hey, do not get up if I give you medication? Improvement efforts. What are we doing as a group or interdisciplinary team to make sure these falls don't happen? And then afterwards, what we do is we reassess. We make sure the patient is not getting dizzy or headaches, because they could have hit their head and we could never know by just looking at a patient. So we want to make sure we keep reassessing. So what is my personal obligation? My personal obligation is to inform my patients of my agreement as their healthcare provider to make sure that I keep them safe. That means I'm explaining to them what I expect from them, and I tell them what they should expect from me. And in that agreement, we want to make sure that they are constantly reassessed and also reoriented to that agreement. I want to be able to support my team, make sure that I'm not only giving effective communication, but I'm also making sure I'm reading, asking the questions, and making sure and clarifying, making sure everything is correct in the patient's chart. I'm focusing on the task. I'm focused on making sure these patients do not fall. Do they have their yellow socks? Do they have their armband? Are we recognizing them as a fallers? Are we answering the question? Are we answering the call lights in time? Are we giving effective communication? Is their scores on the in the system correct? Let's see. All right, so the potential outcomes related to chain. Okay, so patient participation. I read a few a few articles. One of them was Vaughn's and a few other doctors that came together, and they wanted to find out how could we prevent falls. And they found that patient participation, when you explain to the patient about what's going on and your expectations of them, they will have a decrease in falls. Family participation, they will also be able to help with the decrease in falls. Staff recognition implementation to decrease falls. As long as staff is understanding and we reorient the staff as well as the patient, as well as the family, everything, in the overall care of the patient, they found that it reduces the cause of falls. That's it.
Good job.